Hey everyone, we're back with another video, and today we're going to be talking about pulmonary hypertension, and we're going to focus on three main topics. And the first one is what actually is pulmonary hypertension, and how that is defined. And then we'll talk about the classification, and with this kind of comes how pulmonary hypertension is managed. And then lastly, we'll talk about the presentation as the pulmonary arterial pressure of greater than 25 millimeters of mercury, or a systolic pulmonary artery pressure of greater than 40 millimeters of mercury, where this is just the pulmonary artery pressure. Pulmonary artery or artery pressure. So that's how it is defined. Okay, and so next we're going to move on to how to remember the 5 classifications. So to help us, we're going to first draw this dotted line down the middle, and we'll figure out in a minute how this comes into play, but it's going to be the mirror line. So the first classification of pulmonary hypertension obviously starts with the number 1. And the number 1 kind of resembles the letter I, doesn't it? So the first classification of pulmonary hypertension is idiopathic. That is idiopathic, and we'll talk about this in a second. But the mirror line also plays an important role here. So if we just mirror that line for number 1, we get what kind of looks like a blood vessel. If you kind of just pretend for a minute that you have blood traveling through, kind of looks like a blood vessel, doesn't it? And so this helps you remember that the second cause of the classification number 1 includes vascular diseases. So vascular, so like kind of collagen related diseases. These include rheumatoid arthritis, SLE, and also scleroderma. Classification 1 pulmonary hypertension is usually the most common type for exams. It's the most common, it's often the most tested one, because it's got a little bit more to it than the other other numbers. And classification 1 normally happens in younger women. And the reason for this is, 1, it's kind of this vascular collagen disease, which just happens to be more common in this autoimmune kind of younger women age group. And also this idiopathic cause of pulmonary hypertension is mediated by the BMPR2 gene. It's a mutation in the BMPR2. And that's kind of the high yield bit, is this BMPR2 mutation. And now the treatment for type 1 relies on the fact that it's kind of this vascular related condition, and the evidence shows that we have things that try and decrease vascular tone. And there's 3 things. There's one, there's an endothelin receptor antagonist, and then we have PDE5 inhibitors, and then we lastly have prostaglandin analogs, and what these in effect try to do is they try to decrease vascular tone. And if you kind of remember from, if you constrict your arterioles, then you increase the resistance. In this way, we're trying to decrease the resistance in those vessels and therefore decrease the pulmonary artery pressures. So now on to number 2, So if we just draw the number 2 next to this line for the second classification of causes, and we just mirror it badly, but if we mirror it, then what we're left with is kind of what looks like a heart. And this is left heart disease. So this is pulmonary hypertension caused by left heart disease. And this is kind of most often left heart failure or any kind of valvular or stenotic condition. This is essentially caused by an increase in the left arterial and or left ventricular pressures, which causes an increased back pressure in the pulmonary circulation. And the treatment here is quite straightforward, and the treatment is to treat the heart failure. If you treat the heart failure, you kind of decrease the pulmonary pressures, and then you're going to improve your pulmonary hypertension. Excellent. So the next classification, if we scroll down a bit further, is type 3. And type 3, if we just put number 3 here, if we mirror that, we've got what kind of looks like a set of lungs. I'm just going to make that very clear. We have a set of lungs. And I suppose I should make this very clear that this is a heart. So type 3 is chronic lung disease. So this is chronic lung disease and like chronic hypoxia as well, chronic hypoxia. And the most common by quite a long way is going to be COPD, but you can also have interstitial lung disease / interstitial fibrosis, and also interestingly chronic hypoventilation disorders like OSA, and this is where the kind of chronic hypoxia comes in. The management of this, and this is where things start to get a little bit easier, is just treat the underlying lung disease. Treat the lung disease. So if you treat the COPD, you treat the ILD as best you can, and the OSA with CPAP, you will improve it somewhat, but ultimately a lot of these conditions are not reversible, so do what you can. Excellent. And so now we're on to number 4, the fourth cause, and I probably have to just extend my line a little bit more. So if we draw the number 4 like this, kind of looks like a 4, and if we draw a person who's sitting on this chair in a very odd position, and they've got a bit of a smile, then this kind of resembles a person sitting in a chair, doesn't it? Number 4. And what happens when you sit in a chair for a long period of time? You get DVTs and you get PEs. And so this is pulmonary hypertension caused by thromboembolic phenomenon. So it's called chronic thromboembolic pulmonary hypertension, and this is often shortened just to CTEPH, CTEPH, chronic thromboembolic pulmonary hypertension. So these patients have like a long history of little PEs that kind of are subclinical. They never present because they don't feel any symptoms, and then later in life, with all the scarring and lung changes, they finally kind of get pulmonary hypertension. And the way to treat this is with anticoagulation, as you would expect. You want to stop anticoagulation. You want to stop them from essentially getting any more of those PEs and worsening their pulmonary hypertension. Okay, excellent. Lastly, we're on to type 5, and I'll keep continuing the line. But essentially for type 5 kind of looks like, I don't think we really need to use the line anymore, the mirror line, but 5 kind of looks like an S, and this is for essentially like the basket that doesn't catch anything else, but I think of it as systemic. For example, sarcoid, hematological disorders, I think of it as sarcoid and sickle cell, like and other kind of hematological. There are a bunch, and this is not kind of an exhaustive list, but disorders there are more. Obviously, systemic kind of includes the SLE and scleroderma and stuff, but this just kind of captures the ones that are not related to the vascular causes. And again, the treatment for this is quite simple. It is treat the underlying condition. Importantly, which we haven't really discussed, but for all types of pulmonary hypertension, we know that there is evidence to show that oxygen therapy and what's called graded exercise therapy, or we can just say exercise therapy, is proven to help all patients with pulmonary hypertension. So in addition to each kind of specific treatment, we still want to consider or implement, if we can, these. Oh, that's a poorly drawn box. All of these. Finally, we want to figure out how we want to talk about how pulmonary hypertension presents. So how it presents. And essentially, it's going to present with, in terms of symptoms, with shortness of breath or dyspnea, fatigue, chest pain, or syncope. So it could be any of these. Of course, it can also kind of present with the underlying condition. And if you kind of cast your mind back, the features of dyspnea, fatigue, chest pain, and syncope are essentially symptoms associated with end-stage heart failure. And indeed, these patients with pulmonary hypertension, their symptoms are caused by right ventricular dysfunction due to the severely increased right ventricular pressures required to overcome the increased pulmonary artery pressures. So essentially, this is caused by increased right ventricular dysfunction, or worsening right ventricular dysfunction. And similarly, the signs are going to follow from that. So we have a right parasternal heave, where you feel that kind of right ventricle thumping. It's due to right ventricular hypertrophy, and you really feel that to the right of the sternum. They'll have a loud P2, part of the heart sound. So that is due to increased pulmonary pressures. So increased pulm pressures causing a faster closing of that pulmonary valve in the second heart sound. So you have the faster closing. So the increased pressures cause a quicker closing of the pulmonic valve. And lastly, you can have tricuspid regurg. And the tricuspid regurg is due to kind of right-sided remodeling and stretching. You know, from the hypertrophy of the right ventricle, stretching, and then eventual kind of dysfunction of it, stretching of the annulus. And of course, lastly, signs of right heart failure. Right heart failure. So there we are. This is my little approach to remembering pulmonary hypertension and how it presents, the signs and the symptoms. And I hope you learnt a little bit from it and enjoyed it. And thank you very much for listening. Good luck with study. Thanks.